honor and a privilege to be here today and to share my work in Canada with you. As Pauline just said, by now it's well over 20 years. I'm going to focus today on patients' healing pathways from informal care to Western medicine to complementary and alternative medicine, and we'll talk about what that means for me and what that means for you in a bit. It is also a product of a collaborative effort with which was once my thesis supervisor, who became my collaborator of over 20 years, Dr. Merrily Kelner, who was in the Faculty of Medicine at the University of Toronto when I found her to do this kind of research. And so I started back in the mid-1980s thinking about going back to graduate school. And I knew what I wanted my research to be on. I was interested in how people combine and mix and match their health care. How did I come about that question? Well, I was a dancer and a school teacher, and then I became a school teacher of dance and theater. And when I first began, in the late 1960s, around 1968-69, my teacher took me to someone called an Alexander teacher, and that teacher teaches postural re-education. It started off in England by someone who was in theater. And when I first began in this person's studio, they were only artists, basically. They were singers, they were famous dancers, people from the symphony, opera singers, theater people. And that was basically the population of this particular man in Toronto. And I kind of took to the technique, to the Alexander technique, incorporated it into my own life as a dancer, but stayed with him for many, many, many years. And over the years, about 20 years, I noticed that the clientele was changing. It wasn't just artists who found him through word of mouth. It was nuns flying in from Chicago. It was truck drivers who had bad back problems. It started to permeate out into the population. So I got to thinking, because I'm married to Barry, a network sociologist, I said, how are people getting here? So I devised a thesis, a master's thesis, which was in the Faculty of Medicine, on how people with low back pain go about getting care. So I looked at patients of orthopedic surgeons, chiropractors. Do people here know what chiropractors are? Yeah? Good. And Alexander teachers who just use their hands to help them grow tall and be in one line. And I chose, because I didn't want it to be just the people I knew and liked, I found, basically randomly, 3 orthopedic surgeons, 3 different chiropractors, and 3 different Alexander teachers. And then I needed a random sample of their patients. And so I was able to, with their help, I said, you know, try to randomize and let me have the names that you have, and I'll choose them. And so I was able to randomly choose patients from each of the doctors from each of the groups. So I personally interviewed 36 patients and clients. And it was a retrospective study, because I was asking people, when they had a low back problem, who was the first person you turned to? What did they suggest, and what did you do? And so I had nice pathways. But I also had the network questions devoted strictly to health. Who do you talk to when you have a health problem? Who gives you information in general? Who gives you information about alternative therapies or complementary therapies? And who gives you information about specific practitioners? So that was how I started, and that was my master's thesis. So it was a retrospective qualitative study. And I did all the interviews, so it was easy for me to code because, and I didn't have anybody else. I did all the coding on the floor with papers and pencils. Now, the phrase complementary and alternative medicine is an interesting phrase because over the years it's taken on different meanings, and part of the meaning of it is also political. When we think about complementary medicine, we think about people using Western medicine and other kinds of therapies or vitamins or prayers in addition to what the doctor might say. Alternative has a different connotation. You reject the medicine and you only go for alternatives. And so that has a different meaning than complementary. In today's world, I notice we're starting to eliminate the alternative and talk only in terms of complementary, and as we'll see, integrative. And integrative really means you integrate, you mix and match the things that you would do for self-care, nutrition, exercise, as well as you might try traditional folk medicine, traditional Chinese medicine, and a whole host of things. So, is that my understanding here in Singapore as well of complementary medicine? Do you have other things other than medical doctors? Do you have chiropractors and folk medicine and herbalists? You do? Okay. And do people use them? Yeah. And so integrative, again, is where we put the two together. What's fascinating is 2 weeks ago, the National Center for Complementary and Alternative Medicine at the National Institutes of Health in the U.S. changed their name to the National Center for Complementary and Integrative Health. So there's I think a zeitgeist shift to it becoming more routinized in our lives. So today I'm going to talk, this is my outline. We all know that traditional and folk medicines and herbalists and traditional Chinese medicine and acupuncture have been around for many, many years in many, many cultures. It's true for Africa and India. Indigenous populations all over the world have always used things from the natural environment and things that were passed down from folk healers and shamans. And so this is not a new phenomenon. And in fact, most of Western medicine comes from traditional and herbs from the past, from history in the past, from all over the world. And then something happened in the 1970s in North America, and that includes Canada and the US. People began to think about other ways of incorporating treatments into their healing journeys. It wasn't just the doctor. There started to be a little bit in the 70s, some distrust of doctors, and people's problems were starting to change. They were going from acute problems to chronic problems. And the doctors were not as successful with chronic problems as they were with acute problems. So people were still in distress and were willing to try some new things. Then 20 years later, David Eisenberg, who was a medical doctor at Harvard, I'm not sure if he's still at Harvard, I think he's left just recently, he was also a barefoot doctor in China, did the first national study in the U.S. of Americans' use of health care in general. He wasn't just interested in whether people use doctors and specialists. He was interested also what else they did. And so he found that people use vitamins, they use prayer, they use chiropractics, they use traditional Chinese medicine, they use therapeutic touch and energy healing, and a lot of things. And that was a seminal work, came out in 1992 when he published that in the Social Science and Medicine. My ears perked up. Maybe we can do that in Canada. So I went to visit Statistics Canada and said, look what they're doing in the United States. Maybe we should get some evidence and see what people are doing in Canada. And they bought it, and they put a few questions into the National Survey, Health Survey, and we discovered with evidence that people were doing fairly much the same things. And then from that, now this was interesting. I had gotten my master's degree in 1990. And Mary Joy, my colleague, my thesis supervisor, was being forced to retire at the age of 65. She didn't want to stop working. I didn't want to go for a PhD, but I knew what I wanted to do. And so we teamed up together, wrote a grant, and we were successful. And we began the first large study of 300 patients in the Toronto area. We wanted to know who was coming, why, how are they getting there, and whether the relationship between doctors and their patients were any different than between practitioners of CAM and their clients. Now I'm using the word clients for practitioners of CAM because they're not, most of them are not doctors, naturopaths, chiropractors. There's some changes, but basically they're clients. And so the pathways to care, which I'll talk about in detail in a little while, because that was our first big study. I asked them to tell me their stories, and the network questions that I asked in my original study. And then we moved to a more recent study on integrative healthcare, and we used two centers in Toronto, and I'll talk about that in a little while. And then I thought, because this is a communications and new media department, we should talk about a little bit and see some of the Pew data, internet data on what people are doing online, mobile phones, and that. Okay, so in 1993, Mary Joy Kelner and I got our first big grant with a lot of money to study 300 patients from 5 different modalities. We used family physicians. Well, we chose them because we wanted a spectrum of care from the most legitimate and recognized to the least legitimate and not recognized. And so our family physician patients served as our control group. We had 4 practitioners from each group and 15 patients from each practitioner. And we wanted to understand the human factors, the individual and social factors that influence people to try new things. So who were these patients? Well, the CAM patients, the complementary and alternative, from all the groups compared to the medical group, differed. There were a lot more women. But that's also not surprising because a lot more women use healthcare in general, and they're the health keepers of the family, of their children, of their parents. So the fact that more women are using it is not too surprising. More women also use family physicians. They're a little bit older. They have higher educational levels, better occupations, good health status, and they have an inclination towards spirituality. So when I asked people whether they were religious, they said they were not religious, they were spiritual. And so we had to add that code because we didn't originally think it existed for our And why were people using it? Well, they were using it mainly for chronic problems. They had low back problems, they were tired, they had low energy, and a lot of people were depressed. Irritable bowel disease, is that something people use here? Irritable bowel disease, Crohn's disease, things like that. And also, they were using it because they weren't getting satisfaction from their family doctors. Their family doctors are trained in a disease model. You have a disease, I give you a pill, you go home, you take it. But they're not as skilled in problems of the body that are becoming, as we live longer and age more gracefully, we also have more health problems, musculoskeletally and in all different kinds of ways. The question was, how are people getting there? So I did something that you might find interesting in your study. I asked people to tell me their stories when they, for their primary health problem that they stated when I asked them what their main health problem is. Who was the first person you talked to? What did they suggest? And tell me as far as I found them, so that obviously my family physician patients may have told me about other things they use, but clearly my Reiki healers, those patients would have been telling me the most, because they had tried so many different kinds of things. So the interviews lasted anywhere from an hour, in one person's case, to 5 hours. Collected that data in 1994 and 1995, and I had a lot of interviewers helping us. There was no way Mary Joy and I could interview 300 people. And again, it was a retrospective study. Tell me, so I'm relying on their memory. So people told me, oh, the doctor told me to go for x-rays for low back pain. But then I had a friend who's, and the x-rays showed I needed physio. So they went from x-rays to physiotherapy. And then they were talking to a friend who had a similar problem. I said, well, I've had luck with this chiropractor. Why don't you try the chiropractor? Or in some cases, even the Alexander teachers. And in some cases, doctors said, if you go to that person, don't ever come back to me again. I won't look at you. And sometimes the people just ignored their doctors, were perfectly successful where they went, and didn't need the surgery that the doctors thought they needed for low back pain. So I also asked them, again, who do you talk to about health in general? And this confirms also the pathways that I drew. So I had 300 pathways from when they first started to how they ended, to the point where I interviewed them, of course. One respondent said, oh my heavens, I've spent $30,000 on alternative medicine practitioners. And her parents had flipped the bill, and she broke down into tears. So again, it's also interesting because if people have difficult healing journeys for very serious things, it could be a very, very sensitive question to ask. So what we really found in that study was that people are not making a choice. They're smart consumers. They'll do whatever they need to do to address their health problem. If they have information and if they have someone they trust So they're smart consumers, and it's complementary. It's not one versus the other. It's common wisdom that people think that complementary and alternative medicine practitioners give you a lot more time to discuss the problems. They're more empathetic. They're, in some cases, they even become friends, which I doubt ever happens with a family doctor. They feel they're partners in care, so that they're not. They know that they're part of the team effort to make their own health work. They're not relying on the doctor telling them, take this pill, go home, and you'll be fine. And because they spend more time and pay more attention, people feel that it's a more satisfactory experience. But our family physician patients said they were also satisfied. I mean, I think all of us keep going to a doctor we like. And so if you're satisfied, you don't leave. But the basis for their satisfaction differed. Family physician patients talked about trust and skills and competence levels and all the training and results. Specialists, the people who your doctor sends you to if you need a cardiac surgeon or a cardiac doctor or a digestive doctor, that they felt rushed and that the doctors were paternalistic to them and kind of remote. And the CAM patients like the active participatory role. They're partners in care. They know that they're not going to be recommended for drugs or surgery and that. Any questions so far? Am I talking too fast? No?
Excuse me. What does CAN mean? I think I missed that part. Sorry. CAN.
CAM, Complementary and Alternative Medicine.
Okay.
All right? Yeah. And for integrative care, I call it IC. Who helps you when you're sick? Elliot Friedson identified the importance of the lay referral system. People in your community who help to define what a health problem is, as well as family and friends and coworkers. The people you see and meet often will give you advice even if you don't ask for it. So you say, I remember when I first started doing my master's thesis, I would go to a party and somebody would say, well, what are you doing your thesis on? And I said, well, I'm looking at health networks and low back pain. Let me tell you my story. And after a while I stopped. When I went to parties, I didn't tell people what I did because I had more backstories than I cared about. So that was Elliot Friedson in 1960. In 1973, Mark Granovator wrote a seminal article on strong and weak ties. I see some heads nodding. And so that became a nice way for me to try to understand what was happening to my pathways to care, to my healing journeys. You know, what kinds of information was flowing and from who. And some of the things I found were interesting. Smaller, dense networks where everybody knows one another do not provide information about health alternatives. But larger networks, not people who may not know each other, provide more advice and support about alternatives. And I can think of Barry's notion of networked individualism. You know, if you're spanning networks of different kinds, you're more likely to pick up information from various networks that you may be in.
We talked about this in class last week, right, everybody?
And heterogeneous networks offer more access to different kinds and sources of information. And homogeneous networks, people of your own kind, do not provide many options because they know exactly what you know. And what I found, though, is when it came to acting on health, on information that someone gave you, it would have to be someone you trusted. And I call them health confidants. Not just anybody. The information could be from anybody. But what you act on is from somebody you trust and know. Otherwise, you don't know where you'd wind up. Now I'm going to segue into a second study we did of patients who attended 2 integrative healthcare clinics. The integrative healthcare clinics, there are different kinds of integrative healthcare clinics. There are integrative healthcare clinics that have medical doctors and non-medical doctors. And in Toronto, we have tons of integrative healthcare clinics that don't have doctors, but have a lot of different kinds of therapies. They may have chiropractic, naturopathy, homeopathy, and Reiki. And then the ones that we studied were ones that had a combination of both, because that's rare in today's world. We know that in North America, many doctors are taking short courses to become needlers, which is a form of acupuncture, which you can learn fairly quickly. They do a short course in chiropractic, or they do a Reiki, they do a few weekends of Reiki, and they become medical doctors who specialize in Reiki. But that's very different than people who have spent their lives, like traditional Chinese medicine doctors, who do acupuncture, but from a TCM point of view. And before the internet and mobile phones, as I said with my first my master's thesis, everything was word of mouth. We used to call that the underground movement. Once you were in the underground movement, you found out about a lot of different therapies that people were using for a variety of things. Today, we have a lot more sources we can turn to. And the internet and mobile phones have made it easier to locate information on specific health issues and also practitioners. Plus, in society, we now have some macro changes. The changes that it's now more, the language is changing to integrative. It's more used. Even when I pick up the New Yorker, I was surprised last month. There was an ad for some of the cancer hospitals saying, we're an integrative hospital. We can't cure your cancer, but we can help you get through. We can help you get through all the medical problems that the chemotherapy and the radiation produce. And we can also work on nutrition, and nutrition can help you get through a lot of things. So the notion of integration is becoming much more salient. And in the US, there are quite a few hospitals that have integrated clinics affiliated with them. There's the Anderson Clinic in Texas with cancer. There's David Eisenberg started an integrated clinic in Boston. And there's the Asha Clinic in San Francisco, which is also the Asha Clinic in Boston. And some of the hospitals in New York and in Maryland with Berman. So there are a lot of different things that are happening and percolating through society, which are making this a lot more available to all of us and not just a very specific population like artists when I first began. And again, people are experiencing chronic problems and also we're also into managing our own health. When I work out in the gym at Kent Vale and I'm listening to Singapore's radio stations, they talk about how you have to keep yourself healthy, how you have to watch your nutrition, how you have to exercise, and they give you exercises and they say, I've done this morning, are you doing your part? And so it's really cute. I love listening to the radio here when I work out. So in the use of the integrative healthcare centers, I was interested, of course, in some of the same questions. Who are the people? What are their individual characteristics? Why are they coming? How are they getting there? And how do they evaluate their healthcare experiences? So IC means integrative care. Now, I said before I'm a medical sociologist. I'm not here to proselytize for any therapy or any treatment. I'm not interested in whether, as a medical sociologist, I'm not trying to show whether it's efficacious, whether it works, whether it's cost effective, although I would like to study that, and those kinds of questions. So therefore, we don't do randomized clinical control trials. Our questions are trying to capture how people manage and what they think. And that lends itself to qualitative material and to retrospective and for getting a holistic view of things. And so it's interviewing and it's using grounded theory. In my first study, I did use SPSS because it was quantitative for 300, and I did use grounded theory for the narratives as well. And we're also noticing, I mentioned before, in the old days it was the disease model of care. You had a disease, you went to the doctor, you got a pill, you had surgery or something, and that was the end of it. But nowadays, with the kinds of problems we have, those are not always suitable. And by now, it's catching on that people are. Eisenberg did one study, he actually followed it up, and found out that more people were using even more different therapies in 1997, 1998. So it's not a huge social movement, but it is part of the modern world to think of health as prevention and wellness, and that's really contraindicative to the disease model of care. So we're researchers, we're not advocates. We're not proselytizing, I'm not saying one is better than the other. I myself use everything. I go to the doctor, I go to TCM, I go to the naturopath, I've even tried Reiki healing because I wanted to know what it was like so that I could understand what my patients were telling me. And so I even have Barry going to a traditional Chinese medicine doctor for acupuncture because I've used it and had a successful experience. Okay, so we've studied 2 integrative healthcare clinics. One is run by a traditional Chinese medicine doctor, acupuncturist, who was a medical doctor in China and runs a huge clinic that encompasses medical doctors, naturopaths, acupuncturists, and I'm just trying to think what else is there. Because there were a couple of, but the interesting thing is
This is in Toronto.
This is in Toronto. But the interesting thing is what happens when you walk in to an integrative healthcare clinic. It's not like a doctor's office. There are waterfalls. They treat you to a cup of tea as you walk in. There are soft colors and beautiful furniture. And the smells are beautiful. So you walk in the door and already you feel as if you're, whatever it is that you walked in with is being addressed. And the chairs are comfortable and you sit there and you talk to people. The second integrative healthcare clinic we chose, it was outside Toronto, was run by a medical doctor, and we wanted the comparison of the two. It was run by a medical doctor who was interested in energy healing and working with mind-body kinds of notions. Now that was in a medical building, but when you walked in, there were still paintings on the wall, there were plants. It had a welcoming feeling, but not as welcoming as the first integrative healthcare clinic. We also interviewed the practitioners, and all of the practitioners in both clinics agreed to be interviewed. But I'm not going to talk about that today unless you have some questions later. We randomly sampled 20 patients from each center. The second center, Center B I'm going to call it, the one out in the suburbs, was interesting. Mary Jo and I were going to sit in on a staff meeting. And they canceled the staff meeting and we had traveled 2 hours to get there. And so, but what they let me do, they let me have their complete patient roster. I had a random numbers table, and I was able to randomly choose 20 patients. In the first clinic, run by the traditional Chinese medicine doctor, I knew the administrative assistant, and she let me have the complete roster of names, and I could pick and choose. Now, I think you might be asking, but aren't some of the patients Chinese? And don't you need a translator to do some of those? It turns out that in both clinics, most of the patients are white Anglo-Saxon. Actually, in the first center, Center A, run by the TCM doctor, there are some very, very famous people. Writers who attend that clinic who are really, really well known in Canada and elsewhere, like Margaret Atwood, Michael Ondaatje. So they help to set the tone also for the kinds of clientele that they get. So some of the questions we asked: what made you choose the center? Did your choice have anything to do with a particular philosophy of care? And if referred by a family member or a friend or a coworker, we asked them about their health problems and experiences at the center. We were 3 project members. I had a sociology graduate student working with us, and Mary Joy and I. Any questions so far? What did we find? So I'm using the same socio-behavioral model that we used at the very beginning. And if you want, those papers are on my website and you can download them so you can get a better sense of the model and how we did it and what we did, because it's spelled out a lot more carefully. In both centers, again, the majority of patients were women, little older, in their 40s and 50s, and most of them, as I said, were born in Canada, and so they were Canadian. In Center A, the one I talked about that had the famous writers, they were highly educated. They were basically university graduates. They were in the arts, the professions, and in the business world. In Center B, many of the patients there were really attracted because of the medical doctor and had been there before it had changed to an integrative center. So it had some of those fuzzy boundaries. They still had professionals, but they also had a lot more blue-collar workers. And in both centers, the incomes were high. I should go back and say that in Canada, we have universal health care for medical coverage. So everybody has access to doctors and hospitals without having to pay. All the other things, all the other therapies you have to pay out of pocket, unless you have an insurance plan that will allow you a reimbursement for some of the treatments for a short amount of time. So generally, people who are paying out of pocket need to have money to be able to do that. But some of our patients said, if it helps us, if it helps our health, we'll sacrifice something else to pay for it.
I have a question. Are these integrative clinics that have both, would the healthcare pay for your visit with like a family practitioner, but then if you had a massage, you'd have to pay for that part?
Yes. And then, okay, which say, I'll mention, Center B actually folded. Center B folded because the complementary practitioners were not bringing in enough money. And the medical doctors were carrying the center, and eventually he said, I just can't do this anymore. I'm an energy healer and my own energy is dissipating and I can't do this anymore. So yeah. And actually, even in Center A, the director there is not drawing much of a salary. She put a lot of money into renovating a gorgeous building. And it's unclear, I'm not sure who's there or not there now. She still has a couple of medical doctors. But I know personally that she's not drawing a huge salary or she's barely making ends meet. I should also say that when you go to complementary practitioners, it's so informal that often they become friends with each other and see each other outside the treatment place. And many of the people who are attracted, many of the camp practitioners who were attracted to Center A, and even the medical doctors, had been friends of hers and knew her for a long time, and she invited them to come in and work at the center. People are still going for a huge range of reasons, from simple colds to Parkinson's disease to cancer, as well as musculoskeletal, the normal aches and pains. And a lot of people are going for energy and fatigue and prevention and wellness. In Center A, the main needs were chronic pain, loss of energy, and also prevention. They didn't want to get sick. And in Center B, again, it was chronic problems, a lot more depression because the medical doctor the director of Center B, focused on that a lot. That was one of his specialties. Headaches as well. And the perceived seriousness, how people perceive their health problems, were greater at Center B. And that was because they were more medically attached and I think had more serious problems. Well, how do people, again, get to the integrative healthcare centers? Center A has a reputation for healing. She was written up in the newspapers, so there was some press. She writes books, so and by now her name has spread through the city. So that when I say something, people basically know who I mean, because I've studied the center, I'm very careful about what I say or I don't say. I basically don't say anything. And in fact, I want to go to Center A myself for some healing, and because I've studied it, I've been reluctant to break that barrier. Although when she sees me in the street, she hugs and kisses me and says, "We should meet and go for a coffee." So again, mostly if you look at Center A, it's by family, friends, neighbors, and colleagues. Only 2 physicians recommended going there and 2 camp practitioners. In Center B, they were attracted by the reputation again of the family doctor. He's got a good reputation as being caring and wonderful and listens. In Center A, people are coming also again for the holistic personal care that combines medical and non-medical. And the same is true for Center B, but some of the people that I interviewed did express dissatisfaction with conventional care outside of this particular integrative center, but of course are appreciating all the good things that the doctor and the CAM practitioners bring. Despite all the hoopla about integrative centers, most people are not getting integrative care. If at most they see 1 or 2 other people, and that's not on a routine basis, it's not regular, and that's interesting because I also study interprofessional collaboration, and medical doctors are at the top of the hierarchy, and everybody else isn't. I mean, we talk about them as one group, but in fact there are many different groups as you go down the spectrum of legitimacy and recognition. And they're coming from different playing fields. They come with different philosophies, they come with different educational backgrounds, and so sometimes it's hard to get them to work together and work through a common language, because they have to come, a TCM practitioner thinks and uses words that are very different than a medical doctor. And so coming to some sort of language, overcoming barrier is an issue. And so collaboration, even in the integrative centers, unless there's a concerted effort to try to bring the team together, there really isn't integrative care. And right now, I know that the one in Boston, David Eisenberg's original, was working very carefully on trying to integrate the team so that they could do team assessments, use the same language, use the same charts, but right now it's still quite separate. But on the other hand, patients are loving the warm, empathetic, emotional attachment they feel with their practitioner. And I've been reading in the New York Times in the last couple of months about how it's not the pills that doctors give you that matters. It's the relationship and the feeling that patients have that you are listening to them and understanding what their problems are. Because we also know that when people go and say they have a problem, it's usually a problem that they're not mentioning that they really have, and not the one that they're presenting. So it's complicated. It's complicated. Most everyone believes that the care they receive helped them. They're satisfied. Their pain has been diminished. They're feeling more energetic. And at the integrative centers, they don't have these doctor-patient hierarchies. I don't know if anybody's read Talcott Parsons' The Silk Road. You form the role, the doctor tells you what to do, and if you don't listen to the doctor, you're in deep, deep trouble. You don't get better. But people in those days believed that the doctor knew best. Today, we know government doesn't know everything, the economists don't know everything. We're skeptical of everything, and so we're skeptical of doctors as well. So this is what a female patient at Center A told me. She liked the idea of combining medical and non-medical. Again, a female patient at Center A, referred by a patient at the center, and I wanted anything that felt natural. Recommended by a coworker. Whoops. Female patient at Center B. I was looking for a family doctor, and my chiropractor, which was unusual, but the chiropractor was attending the integrative clinic. And again, I don't like to take conventional medications. What people don't realize is that even the treatments, the non-medical treatments, also have, could have negative consequences in terms of what they're taking. There's a lot of work being done now on natural products and herbs. For instance, there's a lot of work being done on turmeric as an anti-inflammatory. As an anti-inflammatory, it could be wonderful for a whole host of problems. So we found the Anderson model also applicable. We're all preferring low tech and being able to have control over what we do and how we do it. And so the idea of a partnership between patients and their practitioners and doctors. I know I have a new family physician, and we're having to get to know each other. She has to know that I don't like medications, and that I try all sorts of other things, and that if they're working, leave me alone. Don't tell me 10 years from now, if I don't do this, all my bones will break. I tell her I'm lifting heavy weights, so my bones will be just fine. And so far, she's agreeing with me. So I think complementary and alternative medicine in the form of integrative medicine is here to stay. It's part of the networked individualism, the fact that we inhabit different spheres around, whether it be online communities, around diabetes, or friends that you talk to, or co-workers, or whatever. The ability to choose and make your own choices, taking control, plus all the abundance of the information online makes all of this so much more doable in today's world. And I said I would show you some data from the online reports from Pew in the Internet and Everyday Life surveys that Lee Rainey, Barry's co-author, runs in the United States. You can see how many people, what percent of the US population is actually going online for health information. And they're going online for specific diseases and specific conditions, treatments and procedures, and to a lesser extent, doctors or other healthcare professionals. And often the search is on behalf of someone else. So children are searching on behalf of their parents who may not know how to use the internet for information. Although now that we're getting older and we started with the internet, we're doing it for ourselves. Mobile phones are certainly changing the way we get information. And again, people aren't using mobile phones, are using it for the same kinds of information, diseases and treatments and general. Again, more women than men seek health information. It's not surprising given what I've said in the past. And adults with health insurance are more likely to use things that they have to pay for. So again, doctors are one source of information. Family and friends are a large source of information. Flows are going in both directions. You tell people something, people respond, and it becomes a conversation back and forth, two-way flows of information. And especially when people have a similar health condition, they're very happy to share all kinds of information with you, whether you want it or not. Okay, I'm not going to go through this because I see time is running out. What I really wanted to say here is that in-person and online networks reinforce each other. So the information you get online works with the information you get from your networks. And patients are now empowered by what they find, so that's also changing the nature of the doctor-patient relationships. You don't want to go into your doctor and be cut off in 18 seconds or 2 minutes. You come in with a host of questions because you found a whole bunch of information and you want to check it out. And so I started to say before, in the New York Times, they're starting to really make doctors understand that they have to make time for their patients. They can't hurry them so they can get through 200 patients in a day. And so I have some questions for you. How do things work here? And are you faced with some of the similar situations as we have back in North America? I now know that MedShield Life became a bill last night. How do you feel about that? Is it going to make a difference?
Are you asking us to answer these questions
Yeah.
now? Oh,
Yeah.
I didn't know.
Yeah, sorry, I'm asking. Is it going to make a difference in how you access health care? Anyway, do you have any questions for me? These are things you can think about.
So in the U.S., certain states will cover a licensed provider of alternative medicine or integrative medicine if they are state licensed. So then the health insurance company has to pay for it. Is there any sort of thing like that in Canada where if you're licensed, then it gets covered?
Not yet. One of the things we looked at was that some of the groups like the chiropractics, naturopaths, traditional Chinese medicine doctors all have schools in the province of Ontario, which is equivalent to a state. And we interviewed them about what they wanted, what their goals were. And their goals were to increase their standards of education and clinical practice so that they could get regulated and be recognized by the government as well as by patients. Several of them have been regulated and are going through the process of setting up the colleges in a way, by college I mean not the education, but the governing bodies for the profession. But we don't see that being translated into money yet. And what also I think I've noticed is that the pie of people using alternative medicine, although I talked about it increasing, they're doing things like vitamins and prayers, not necessarily going to different people. So there are more people practicing, but not that many more people who are going. So unless you are really, really good, and the word of mouth is really, really good, you don't succeed. Your business falls under. And now that may change in the next 20 years with all the evidence that's mounting and all the studies that are starting to happen. The National Institutes of Health is starting to put a lot more money into studying different things than when I began in 1998, when I went to visit the National Institutes of Health. And at that time, too, they were interested in studying medicine, but they weren't interested in studying anything else. Or even looking at the social science aspects of it. So, yeah, so no, there's not that much more money to be had by being regulated at this point.
Can I ask a question?
Sure.
As you have studied this CNM for 20 years, do you find there's like differences in the trends? Like maybe in the past, is it like more white people want to use it? But is it because I know the population in Toronto is like more Asians?
Yes.
So is there any differences now?
Most of the clientele are white. And I've interviewed a lot of traditional Chinese medicine doctors, acupuncture in Toronto. There are a couple of Chinese doctors in particular areas that would have a Chinese population. But most of their clients are white.
But I think that a lot of Chinese people in Toronto, we have 500,000 by the way,
Yes.
out of 3 million, take herbs along with Western medicines.
But is it they will go to a specific
Yeah.
like TCM clinics instead of those like more integrated clinics?
Right now, yes, because there aren't too many integrative clinics, and they don't work as integrative clinics.